Welcome to Coffee with Kyle number 14. I'm Kyle Ridgway. Good evening, actually. So this is going to be Coffee with Kyle with a twist. It's the evening time, so this is going to be Beer with Ridge. Now, this morning I actually wanted to talk about plausibility and the evidence hierarchy. But a conversation this evening has kind of pivoted me in a different direction. So I had the pleasure to speak with a young practicing acute care physical therapist on some pretty heavy topics, and I decided to pivot tonight's conversation in that direction. So I first want to read a post that she had posted in the DPT student Facebook group prior to getting into tonight's discussion. So she had posted, "Attention acute care PTs. Do you guys feel drained and heavy after long days of seeing so many sad stories and just unfair amounts of suffering? Yeah, we help people improve, but some people's lives are just so hard and sad. How do you guys deal? I'm about to go for a run, so there's that. But long term, what ways have you found to successfully cope? It's like empathy is wonderful, but also opens the door to soak some of that stuff in. Serious response is appreciated. Your girl's feeling down." This post immediately resonated with me, so I reached out to this young clinician, and we set up actually a Skype call, which again happened this evening, and she kind of allowed me to share this story and to talk about it a little bit. And I think first of all, this is a tough topic. I don't think that our profession particularly talks about it a lot, but it's becoming much more in the spotlight, especially in critical care medicine and critical care nursing. Burnout, compassion fatigue, the concept of resiliency are all kind of being recognized as concepts within medicine generally and critical care specifically. And let's go to my precision language obsession. So first thing I want to do is define a few things. So from the definitions that I've found or interacted with, compassion fatigue is a state experienced by those helping people in distress. It is an extreme state of tension and preoccupation with the suffering of those being helped, to the degree that it can create a secondary traumatic stress for the helper or the caregiver or the clinician. Now, burnout has been well characterized in quite a lot of professions, and the syndrome itself has been defined as or characterized by depersonalization, emotional exhaustion, and loss of sense of achievement in clinical care. Unfortunately, the incidence of burnout among medical professionals across disciplines appears to be rising. Although, to caveat that, or the dichotomy is that some of that improved awareness may be due to improved awareness among professionals and improved diagnostic capabilities. So, in other words, the rate of burnout foundationally may actually be the same as it was historically, but our ability to diagnose and recognize it may be higher. And so I think there's a lot of interesting things at play here, and as many of you who have interacted with me or have talked to me, I work primarily in a medical intensive care unit. I work in an academic acute care hospital with a high acuity of patients. The unit that I work in has a very high mortality rate, and I will be the first to admit that I do not see or experience nearly as much as my nursing, respiratory, even pharmacy, CNA, you name it, colleagues who are literally at the bedside as people are dying and have died. And I think that's really important to recognize and to understand. And I want to go down the route of burnout and compassion fatigue and the remarkable distress that critical care clinicians may face, and then pivot it and tie it back to what happens in the physical therapy profession. So as this is becoming more recognized in critical care and in medicine and in healthcare in general, people are starting to talk about it more and talk about how to deal with it. And I think it's just important to remember what some of our colleagues are facing to help us kind of parse out our own experiences. So I'll give the example that I know that is my local environment. So in my medical ICU, there's a high mortality rate. Around 15 to 17% of all admits will die that come to our medical ICUs. So that's about 1 in every 6 patients. About 1 in every 4 patients who requires mechanical ventilation will pass away in our unit. And I think it's important to think about the logistics of that. So there's obviously the profound suffering of the patient and family approaching an end-of-life scenario. And it's important to think about who's at the bedside there. The nurse is at the bedside, potentially for a 12-hour shift, potentially for multiple 12-hour shifts. And they're the ones procuring care, interacting with that suffering. The physicians are the ones that have to round and talk to the family and parse out conversations regarding care plans and what the next steps are. And when the unfortunate but inevitable event occurs, the nurse is often the one right at the bedside trying to ensure that that patient is comfortable, interacting with the family, administering medications, assessing their effect. Is it not enough medication? Is the person anxious? Are they short of breath? Do they have air hunger? And that, I can't imagine, cannot be an easy scenario regardless of how long you've done it for. But now the patient passes, and the nurse is still at the bedside and is comforting and at least in the space with the family. But the nurse has to get the physician, who now needs to pronounce this patient deceased. The person who does this is oftentimes a medical intern. They may have been a physician for less than 6 months. Many of them don't have any formal training in this yet. They may have to ask a colleague. They may have never interacted with this ever. They may not have been cognitively or emotionally prepared for this. And then there is the logistics. Nurses actually have a flow sheet. For those of you who work in a hospital, maybe work with Epic, we have flow sheets. They actually have a flow sheet about post-mortem care that they have to not only document, but they have to do. So once a patient passes, the nurse is the one who removes the IVs. The respiratory therapist removes the endotracheal tube if the patient was intubated right before they pass. And the nurse is the one who has to put the patient into a body bag. Now, the reason I bring this up is that there is some statistics that suggest that critical care nurses have a similar rate of post-traumatic stress disorder as Iraqi war veterans. This is a very important statistic, I think, to take in mind to understand the level of distress and the level of distress that may be present here, but as well as the profound nature of what's going on. Again, I don't admit or try to even claim that I can say that I've had that level of interaction with patients on a regular basis. Yes, have I worked with patients who have been near to the brink of death and have ended up dying? Sure, but I've save one scenario, I've never been at the bedside as a patient has actively transitioned into dying. So it's not surprising that these things happen, right? This is a very traumatic scenario. The nice thing is that medicine and healthcare seem to be recognizing it and trying to build programs to address this, to address resiliency, to kind of drill down on some of the root factors, and we'll come back to that. So now I want to pivot it back to physical therapy. I'm passionate about the field of physical therapy, but I think we have done our students and young clinicians no favors by ignoring the fact that even though we rally around getting patients better, we rally around the fact that we can help address a portion of the opioid crisis, that we're all about function, that we get people back to living, that we get people moving, that we give people hope. These are all true, but they're not true absolutely. We deal with people who oftentimes are at their most painful and lowest points potentially in their life, dealing with remarkable existential threats and primary losses. And this is true regardless of setting. I'm not trying to argue that my setting is any more profound than anyone else's. It's all about perspective. And the counterexample that I will use is Think of the 17-year-old soccer player whose dream is to go to college on a D1 scholarship. And this young lady, this young girl, tears her ACL. She has now lost her primary identity as a soccer player. Her future is now in jeopardy. She's lost what kind of defines her. For her, for that individual patient, that is no more profound than the patient who is remarkably sick in the hospital. In relative scale, or in absolute scale, it seems totally different, but in relative scale, it's not. So whether we work in an outpatient adolescent sports or in medical ICUs, we're dealing with people who are at very profound turning points in their lives, in high stress environments, with a lot of distress, with a lot of threat to their identity and to their being. And I don't think that we've done a good enough job trying to prepare students of all disciplines, but specifically in physical therapy, because that's what I know, with the cognitive and emotional skill set to parse that landscape. And this is a term that I learned from my friend and colleague Eric Kruger, who's a physical therapist getting a PhD in experimental psychology, is this expectation of relief, or almost this expectation that we can help everything, sets us and patients up for failure. And we need to recognize what we're interfacing with so that we can actually talk about it. Because if we don't all admit that things affect us, then we can't come up with the skill set to do it. And I've written previously, and I'll link to this in the comments, that you don't have to care to be caring. And that's an insight that I had from reading some writings by Keith Waldron, who's a brilliant, inquisitive, very insightful physical therapist, and he's going to hate me for saying as much, but he deserves the accolade. And when I was exploring that, what I realized is that, you know, the pendulum is always swinging, and we're always at risk of having it swing too far. And when we swing too far and we're too emotionally invested or too emotionally affected by the distress, the suffering, the inequality, and the madness, quite frankly, that we see in the healthcare system, the trauma can sum. The trauma can multiply to where every new piece of suffering, every new inequality, every new ridiculous rule and cumbersome process just reopens all the other suffering and trauma that we've seen. And the issue is that the pendulum, as a reaction, can then swing the other way, where we become cold, we become cynical, we start to experience compassion fatigue. And the thing that I think is important is that you can't resilience yourself out of all of this. And that's my personal take, is that there are always going to be cases that affect you. There's always going to be times that the pendulum swings too far this direction and you are too invested in patient cases. And there will be times that the pendulum swings the other way. I think with experience and with studying some of these concepts and understanding what we're interfacing with, understanding the statistics of our population, understanding that there's a lot of people that don't get better, can't get better, won't get better, despite maybe the best processes or the best interactions we can give them, hopefully we can tighten the swing of that pendulum. But even still, there will be cases that pull you the other direction and cut deep to the depths of you, or there will be incidents that you never predicted that will affect you in ways that you can't imagine. And the reason that I think this is important is this ties into social media and how people present themselves on social media. And again, I'm not claiming that this is not me, because we're all guilty of this. Because on social media, there's what's really presented. If you think about Instagram and all the pictures on Instagram, who posts the picture of Instagram of their dirty room, of the kitchen that they didn't clean, of something they forgot to do, of a mistake they made? No, they don't. Social media is not reality. It's an idealized representation of how we would like our life to be. And the reason that is important is it's very easy when you engage with other professionals on social media to think that everyone else gets all their patients better, everyone else's patients are getting better, and no one else fails. Well, we all fail. I've made more mistakes than I would care to admit here in public on video. And hopefully I've learned from them, but I continue to make mistakes all the time. We all, I think, should be open and honest with each other, but that lends itself to a conversation that we can be open and honest that I've cared too much about cases. I've cared too less, or not enough about cases rather. I've been cold, I've been crass, I've been dismissive, I've been frustrated at families. I didn't sit down and listen when I should have listened. I let comments slip by that would have been opportunities to engage and educate and interact and maybe change the course of someone's experience. And I've gotten too invested in cases, too invested in the actual outcome, and been too affected by that. I can admit that I've cried in the stairwells of my hospital multiple times, that I've escorted people on my team and in my unit, off the unit in tears. That's a real life thing, and all of us feel that. And so, as I was talking with this young clinician tonight who's been practicing for less than 6 months, it struck me how much of a disservice we do by idealizing what we do. What we do in healthcare is absolutely profound. But we need to balance and augment that idealism with reality. And the reality is that we are going to see significant suffering in a cumbersome context with ridiculous rules and not enough time and perverse incentives and not nearly enough training to step into the suffering that we are about to see. And so if we don't talk about this, we don't support each other across disciplines, I don't think that we can move past this. And this is all relative, right? So everyone has this in their setting, has burnout, has compassion fatigue. It's a real thing. The dichotomy is we need to be careful about overemphasizing it, and then therefore by talking about it so much, we actually make it more of an issue than it needs to be. Because like I said, I don't think you can train yourself out of this. I've seen attending physicians who have 20 years of experience bawl after a bad patient case. Not after every patient case. That's maybe a red flag that someone's burnt out or doesn't have the support they need or needs to talk about something. But not never. And I think that's an important message for all of us to hear, because I've seen my nursing and RT and physician colleagues interact with situations that would sound stranger than fiction and more horrific than anything you could think up in your mind, and yet they still come in the next day to combat that fire, to step into that madness. And as one of my favorite colleagues has said, is sometimes you feel like you're bringing a squirt gun to a forest fire. And I think oftentimes in these profound existential situations, which is what we do as therapists, we're seeing people at low points, not at high points, that we have to admit that sometimes it's okay to recognize and understand you are at a forest fire with a squirt gun. But as long as you point it at the right direction and you empty that squirt gun of every last drop, you've done a remarkably positive thing. I want to read a quick quote from one of my friends and mentors, Jason Silvernail, which is, we should not shoulder the burden of every outcome. Sometimes we do the best thing and outcomes are horrible. Sometimes we do the completely wrong thing and the outcome is great. But he has said, when I freed myself from the responsibility for the outcome of the clinical encounter, something interesting happened. I freed my patients from blame also. So I think that's all I've got for you this evening on a little twisted segment, Beers with Ridge instead of Coffee with Kyle. So as I leave you here this evening, remember the profoundness of what we do, but recognize that failure, death, and poor outcomes will exist, and make sure you support each other and find someone to talk to. Have a good evening.